Welcome to the lecture on psychological disorders. Although challenging, it is essential for psychologists and mental health professionals to agree on what experiences and actions constitute the presence of a psychological disorder. Inner experiences and behaviors that are atypical or violate social norms could signify the presence of a disorder. However, each of these alone is inadequate. From time to time, we all experience anxiety, have unwanted thoughts, moments of sadness. Our behavior at sometimes might not make much sense to ourselves or to others. So it's important to have some guidance to determine what makes a typical reaction to life experiences different from a psychological disorder. It is generally accepted by members of the American Psychiatric Association that a psychological disorder is defined by significant disturbances in thoughts, feelings, and behaviors. These disturbances must reflect some kind of dysfunction, biological, psychological, or developmental, must cause significant impairment in one's life, and must not reflect culturally expected reactions to certain life events. A first step in the study of psychological disorders is carefully and systematically discerning the significant signs and symptoms. How do mental health professionals figure out whether or not a person's inner states and behaviors truly represent a psychological disorder? Arriving at a proper diagnosis, that is, appropriately identifying and labeling a set of defined symptoms, is absolutely crucial. This process enables professionals to use a common language with others in the field and aids in communication about the disorder with the patient and the public. A proper diagnosis is an essential element to guide proper and successful treatment and guide research into causes and cures. For these reasons, classification systems that organize psychological disorders systematically are necessary. A common tool used in classification is the Diagnostic and Statistical Manual of Mental Disorders, or the DSM-5, developed by the American Psychiatric Association. The DSM-5 details the criteria for diagnosis and treatment of a number of psychological disorders. The DSM-5 is the American Psychiatric Association's authoritative classification of mental disorders. Each entry in the manual includes an overview of the disorder, including diagnostic features, specific symptoms required for the diagnosis, or the diagnostic criteria, prevalence information, or what % of the population is thought to be afflicted with the disorder, risk factors associated with the disorder, and comorbidity rates, or the likelihood of the co-occurrence between two disorders. The DSM is not the only classification guide. Some professionals may use the ICD, or the International Classification of Diseases, which is an index of mental and physical diseases and the criteria for their diagnoses, published by the World Health Organization. There are different approaches to understanding psychological disorders. The biological perspective views psychological disorders as linked to genetic factors, chemical imbalances, and brain abnormalities. The psychosocial perspective emphasizes the importance of learning, stress, faulty and self-defeating thinking patterns, and other environmental factors. While any researcher might focus on one perspective over the other, the two are not mutually exclusive. An example of an approach that values both perspectives is the diathesis stress model. This model suggests that people with an underlying predisposition for a disorder, or a diathesis, are more likely than others to develop a disorder when faced with adverse environmental or psychological events, such as stress, childhood maltreatment, or other negative life events. We'll begin with an overview of some of the different disorders classified in the DSM-5, starting with anxiety disorders and related disorders. Anxiety disorders are a group of disorders in which a person experiences excessive, persistent, and distressing fear and anxiety that interferes with normal functioning. Anxiety disorders include generalized anxiety disorder, which is characterized by a relatively continuous state of tension, apprehension, and dread. It also includes panic disorder, which is defined by sudden and overwhelming panic, even though there is no apparent reason to be frightened. Phobias are specific fears and avoidant behaviors. One example of a phobia is agoraphobia, which is an intense fear and avoidance of situations in which it might be difficult to escape. Individuals with panic disorder often exhibit agoraphobia. Let's distinguish a bit more between generalized anxiety disorder and panic disorder. Generalized anxiety disorder is characterized by a continuous state of excessive, uncontrollable, and pointless worry. People with panic disorder have recurrent and unexpected panic attacks, along with persistent concern about these panic attacks. They worry about the consequences of the attacks and engage in self-defeating changes in behavior related to the attacks. And as mentioned previously, people with panic attacks can sometimes also have agoraphobia, which is fear and avoidance of certain situations and places, in this case due to the anxiety-provoking thoughts of having a panic attack. So what is a panic attack? The experience of a panic attack is very intense, which is why the fear of it happening can lead people to not want to leave their homes. A panic attack is a period of extreme fear or discomfort that develops abruptly and reaches a peak within 10 minutes. It is accompanied by intense physical symptoms. People may experience sweating, trembling, feelings of faintness, a fear of losing control, going crazy, or dying. Many individuals who are experiencing their first panic attack may go to the emergency room believing they are having a heart attack. Although related to anxiety disorders, post-traumatic stress disorder is now classified as a trauma and stressor-related disorder in the DSM-5. PTSD is defined as a disorder in which the experience of a traumatic or profoundly stressful event, for example, combat, sexual assault, or a natural disaster, produces a constellation of symptoms that must last for 1 month or longer. These symptoms include at least a month of intrusive and distressing memories of the event, flashbacks, avoidance of stimuli or situations that are connected to the event, persistently negative emotional states, feeling detached from others, irritability, proneness to outbursts, and a tendency to be easily startled. Not everyone who experiences a traumatic event will develop PTSD. A variety of risk factors associated with its development have been identified. Obsessive-compulsive and related disorders are a group of overlapping disorders that generally involve intrusive, unpleasant thoughts and repetitive behaviors. Many of us experience unwanted thoughts from time to time, for example, craving something while dieting, and many of us engage in repetitive behaviors on occasion, for example, pacing when nervous. However, obsessive-compulsive and related disorders elevate the unwanted thoughts and repetitive behaviors to a status so intense that these cognitions and activities disrupt daily life. The most well-known disorder in this category is obsessive-compulsive disorder, or OCD. People with OCD experience thoughts and urges that are intrusive and unwanted, called obsessions. And they also experience the need to engage in repetitive behaviors or mental acts. These are called compulsions. A person with this disorder might, for example, spend hours each day washing their hands or constantly checking and rechecking to make sure that a stove, faucet, or light has been turned off. Common obsessions include concerns about germs and contamination, order and symmetry. Compulsions are repetitive and ritualistic acts that are carried out primarily as a means to minimize the distress that obsessions trigger and to reduce the likelihood of a feared event, at least in the individual's mind. Compulsions often include behaviors such as repeated and extensive hand washing, cleaning, checking, for example, that a door is locked, or ordering items, such as lining up pencils in a particular way. Depressive disorders are another category of disorders recognized in the DSM-5. Sadness is a normal and adaptive response to some life events. However, there is a distinct difference between feeling sadness after hearing bad news and depression-related disorder. We will cover two disorders in which depression impacts daily functioning on a psychological, cognitive, and behavioral level. Major depressive disorder, or MDD, has criteria that must be met according to the DSM-5. As we know that depressive symptoms can arise for a number of different reasons, it is first necessary to rule out that drug or alcohol use or other medical conditions are not leading to the depression. An individual must present either depressed mood or loss of interest for at least 2 weeks, along with some other symptoms, such as trouble regulating appetite or sleep, loss of energy, physical agitation, feeling listless, feeling worthless, or thinking repetitively of death and suicide. A person with bipolar disorder experiences mood states that swing between depression and mania. The person's mood alternates from one emotional extreme to the other. To be diagnosed with bipolar disorder, a person must have experienced a manic episode at least once in their life. Although major depressive episodes are common in bipolar disorder, they are not required for a diagnosis. According to the DSM-5, a manic episode is characterized as a distinct period of abnormally and persistently elevated, expansive, or irritable mood and abnormally and persistently increased activity or energy lasting at least 1 week. And these last most of the time during each day. During a manic episode, some experience a mood that is almost euphoric. They might become excessively talkative, sometimes spontaneously starting conversations with strangers. Others might become excessively irritable and complain or make hostile comments. The person may talk loudly and rapidly, exhibiting flight of ideas, abruptly switching from one topic to another. During a manic episode, individuals usually feel as though they are not ill and do not need treatment. However, the reckless behaviors that often accompany these episodes, which can be antisocial, illegal, or physically threatening to others, may require involuntary treatment. Some patients with bipolar disorder will experience a rapid cycling subtype, which is characterized by at least 4 manic episodes, or some combination of at least 4 manic and major depressive episodes within 1 year. 1 in 100 people experience it over their lifetime, and half report onset before the age of 25. It's more common in men. 90% of those with bipolar disorder have a comorbid disorder, most often an anxiety disorder or substance abuse problem. Schizophrenia is a devastating psychological disorder that is characterized by major disturbances in thoughts, perception, emotion, and behavior. About 1% of the population experiences schizophrenia in their lifetime. Usually the disorder is first diagnosed during early adulthood. Most people with schizophrenia experience significant difficulties in many day-to-day activities, such as holding a job, paying bills, caring for oneself, such as grooming and hygiene, and maintaining relationships with others. Frequent hospitalizations are more often the rule rather than the exception with schizophrenia. Even when they receive the best treatments available, many with schizophrenia will continue to experience serious social and occupational impairment throughout their lives. Schizophrenia has positive and negative symptoms. Positive symptoms of schizophrenia are symptoms of commission, meaning they are something that individuals do or think. Examples include hallucinations, delusions, and bizarre or disorganized behavior. Negative symptoms are those that reflect noticeable decreases or absences in certain behaviors, emotions, or drives. So, for example, flat affect or showing no emotion in the face. We know that communication between regions of the brain rely on neurotransmitters or chemical messengers. One possible biological mechanism that underlies schizophrenia is the overactivity of one particular neurotransmitter, dopamine. Support for the dopamine hypothesis comes from the effects of drugs that impact dopamine activity in the brain. Dopamine antagonists block the transmission of dopamine, which leads to a decrease in schizophrenia symptoms. Dopamine agonists, on the other hand, bind to dopamine receptors and increase dopamine transmission. This leads to an increase in symptoms. Individuals with schizophrenia have brain activity patterns and brain structures that look different from healthy individuals. There are prenatal factors that may lead to such brain abnormalities. For example, low birth weight, maternal gestational diabetes, older paternal age, oxygen deprivation during delivery, fetal virus infections, and genetics. The next disorder we will cover are dissociative disorders. Dissociative disorders are rare and controversial. The singular experience of dissociation is not so rare. For example, many of us can likely think of a time where we felt as if things were unreal, where we maybe felt like we were watching ourselves as if in a movie. Or we've experienced a time where we've driven home and don't remember exactly driving there because we were preoccupied. Although this type of dissociation from reality is common, it happening enough to be categorized as a disorder is not common. Dissociative disorders are characterized by periods of time where conscious awareness becomes separated from previous memories, thoughts, or feelings. People may experience fugue states, which are defined as sudden loss of memory or a change in identity that might often arise from extreme stress. One specific disorder, formerly known as multiple personality disorder, is dissociative identity disorder, or DID. Here, a person exhibits 2 or more distinct and alternating personalities. Skeptics argue that DID is created by therapists. Others claim it is real and cite evidence of distinct body and brain states for each personality in neuroimaging studies. Personality disorders are characterized by inflexible and enduring patterns of behavior that impair social functioning. These are divided into 3 clusters in the DSM-5. Those with paranoid personality disorder harbor a pervasive and unjustifiable suspiciousness and mistrust of others, and are reluctant to confide in or become close to others. They may read hidden meaning or threatening meaning into benign remarks or events and take offense easily and bear grudges. This is not due to schizophrenia or other psychotic disorders. Those with schizoid personality disorder exhibit a lack of interest and desire to form relationships with others. They are aloof, show emotional coldness and detachment. This is not an autism spectrum disorder. Those with schizotypal personality disorder exhibit eccentricities in thought, perception, emotion, speech, and behavior. They show suspiciousness or paranoia and have unusual perceptual experiences. This is not due to schizophrenia or another psychotic disorder. Cluster B personality disorders are characterized by dramatic or erratic behaviors. Those with antisocial personality disorder continuously violate the rights of others. They have a history of antisocial tendencies prior to the age of 15 and often lie, fight, and have problems with the law. They are impulsive and fail to think ahead, and lack feelings for others and remorse over their misdeeds. Someone with histrionic personality disorder is excessively overdramatic, emotional, and theatrical. They feel uncomfortable when they are not the center of other people's attention. Their behavior may be inappropriately seductive or provocative. Their speech may be highly emotional but often vague. They may alienate friends with their demands for constant attention. People with narcissistic personality disorder have an overinflated and unjustified sense of self-importance and are preoccupied with fantasies of their own success. They believe they are entitled to special treatment from others. They may show arrogant attitudes and behaviors and take advantage of others without remorse or empathy. Those with borderline personality disorder have an unstable self-image, mood, and behavior pattern. They cannot tolerate being alone and experience chronic feelings of emptiness. They maintain unstable and intense relationships with others. Their behavior is often impulsive, unpredictable, and sometimes self-damaging. They can demonstrate inappropriate and intense anger and can make suicidal gestures. Cluster C personality disorders are characterized by anxious and fearful behaviors. Those with avoidant personality disorders are socially inhibited and oversensitive to negative evaluation. They may avoid occupations that involve interpersonal contact because of fear of criticism or rejection, and also tend to avoid relationships with others unless guaranteed to be accepted unconditionally. These individuals feel inadequate and view the self as socially inept and unappealing. Those with dependent personality disorder allow others to take over and run their life. They may be submissive, clingy, and fear separation. These individuals cannot make decisions without advice and reassurance from others and feel uncomfortable or helpless when alone. Finally, those with obsessive-compulsive personality disorder, not to be confused with OCD, have a pervasive need for perfectionism that interferes with the ability to complete tasks. They may be preoccupied with details, rules, order, and schedules. They are excessively devoted to work at the expense of leisure and friendships, and rigid, inflexible, and stubborn.